dear guests, I welcome of the entire Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, a highly acknowledged scientific program dedicated to exploring multifaceted landscape of cardiology. This program serves a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected co-director, Dr. T.B. Keshavamurthy sir. Sir is consultant interventional cardiologist and HOD at Manipal Hospital, Mysore, past president of CSI Mysore chapter.
Network might be some error with the network error.
Yeah, he joined back. There's some technical.
Right, sir. Yes.
You are muted.
Rishikesh, sir,
Yes.
sir, you are on mute, sir.
Muted.
Sir has several national and few international publications and presentations to his credit. Sir has at Victor Hospital, Mysore. Sir participated as principal investigator in landmark clinical trials and other national clinical trials and registries. Thank you, sir, for your continued guidance and support to run this program successfully. Our distinguished moderator, Dr. Himanshu Gupta, sir, is poised to share his knowledge, insights, and practical wisdom to empower us in the fight against the global challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderator for today. Sir is Senior Consultant Interventional Cardiologist in the Department of Cardiology at Medanta Heart Institute, Lucknow. Sir is well trained in interventions like primary elective PTCA, primary peripheral angioplasties, complex PTCA, including CTO interventions, TAVI, TAVR, and other valve interventions, pacemaker as well as device implantations and pediatric interventions. Sir did complex CTO case presentation in CTO Club, Japan. International, sir participated as international course faculty and complex case presentation in award session in Master Course 2024 in German Heart Center, Munich. Sir did complex case presentation in India Live 2023, NIC 2022, and IJCTO 2022. Sir is lifetime member of Cardiology Society of India and Society of Cardiac Imaging and Physiology. Sir did paper presentation in award paper session at Indian College of Cardiology, Kerala chapter. Sir also has various publications in reputed journals to his credit. Thank you, sir, for joining today's program. I would also like to introduce and extend a warm welcome to our esteemed speaker for today, Dr. Pranav Kamrat, sir. Sir is concerned cardiologist and director at D.L. Walawal Medical College and Hospital, Chiplun, Ratnagiri, Maharashtra. Case he is presenting today is on complications during coronary interventions. Thank you, Dr. Pranav Shamrat, sir, for accepting our invitation to present the case. And finally, I would like to extend a special welcome to all the delegates who joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our course director. The meeting will proceed further with the case presentation by Dr. Pranav Shamraj, sir. Following this, we'll have a discussion on the case where all the faculty members will participate. Second case is again on the same theme on complications during coronary interventions today, and this will be presented by our respected course director, Dr. Keshavamurthy, sir. And this will be followed by the discussion among the faculty. Post the second case, we'll have the concluding remarks by our course director, Dr. Keshavamurthy, sir. I request audience to put their questions in the chat box so that at the end of the discussion, we'll take up those questions. So without further ado, let's embark on this educational voyage together as we endeavor to enhance the lives.
Very good evening and thank you, Emcure. My regards to Keshavamurthy sir and Himanshu Gupta sir for allowing me to be a part of this forum. So I am presenting my case, which was a simple case but had difficulties, and how we got away from it. So this patient has a very distinct clinical profile. That's why I have put it into this, that he is a young male. He stays just 2 kilometers next to our hospital. Ours is a medical college, a tertiary center. But like for the cath lab running, I am the only one cardiologist here. So this is a young chap. He owns a business and pretty well to do financially. So his risk factors are he has a diabetes for 10 years. He has a family history of ischemic heart disease. Father died of STEMI at the age of 70. And for diabetes, he's on polytherapy. And with that, the sugars were fluctuating uncontrolled for a long time, but controlled after good pharmacotherapy. He's also hypertensive since the same time. He has dyslipidemia with a LDL level of almost 170, which comes down after the statin usage. The drop is almost by 30 to 50%. But again, as being in a rural setup and in a like a metro thing, the patients generally do not comply well with the drugs, and also they keep on going to different cities to seek medical help, and then there is a lot of alteration in the medication. So this patient, he is a sportsman. He plays cricket. Then he is very active in swimming. And generally, he accompanies a lot of other patients as a social worker also, and as a financial aid to a lot of poor patients. So this time, he undergoes all his physical checkups, and I mean, for their all yearly checkups, insurances, they are all partnered with us. So his all workups are pretty well. I mean, he's well aware of everything. And also he has a very good lifestyle. He's non-addict. Every morning he gets up at 4 o'clock. He does almost 1 hour of the morning course in terms of pranayam, yoga. And he's also very active physically. So his morning 3-4 hours are dedicated to a lot of physical work. The only thing is he is very type A anxious personality, and also overstressed in his business and work profile. So his recent lab parameters were well-controlled sugars and lipids. Now, this fellow came to me with chest pain, which was atypical pain. I mean, he was not able to describe the pain. He was having vague discomfort, and he was very much active. And he said, "I'm just getting pain, which comes and goes off." And when he had come, like this is a presentation 2 days prior to when he landed up in the emergency. So his ECGs, echo, even the biomarkers we had done 2 to 3 times were normal. And as usually, he was not willing for any workup. His younger brother had undergone a CT coronary angiogram where he had mild plaques, but he was like, "No, I am okay. I don't want to do this," in his regular workup. So with this complaint, I just thought I advised him a CT coronary angiogram, but again, that was not available and he had to go to Mumbai. So with the same rescue, I just planned a stress test for him. And the TMT was negative at 13 minutes, and that was expected. He was very much athletic person. And also he's a lean guy with a BMI almost of 25. So again, I advised him a CT angio, though stress test was negative. Also the advanced cardiac profile, because to see what is his LP and other things. But then he just said, "I'm okay," because he got a reassurance that, okay, things are good. Now, after all this, like in the midnight, 12 o'clock, I got a call that this person has again come with chest pain. And this time he had a very typical sweating, extreme level of uneasiness. The presentation like a STEMI, and it was the ECG showed a hyperacute ST elevation. Without wasting any time, we attended the case and immediately thrombolized him within that best window period. And he was pain-free, all successful lysis, completely normalization of ECG, and it was all planned that to stabilize him and take him up in the regular hour. So, and also he had stabilized. So CAG was scheduled for him in the regular hours, but unfortunately, what had happened that he had a family history. His father had presented in a similar way. Midnight, was again thrombolized, but he could not see the next day morning. So all the relatives and he had a huge number of relatives. were very anxious. So they said that we don't want to wait for the morning. So whatever that we want the things to be done immediately. So with this, we instead of the regular, we posted this case for midnight, like almost 12:30 to 1 o'clock. Now, this patient, the angiogram, the right coronary injection shows a very good RCA. There is not much of any critical lesion. And if on the left, on the right shoot, we can see there is a lot of calcium seen in the the LCX or the left main to the LED, the view. And so the left side, I hooked directly with the guiding catheter. And the left shoot showed a very critical osteoproximal LED, 90 to 95% lesion. And this is the epicranial view, which is showing that critical lesion in the proximal LED, then some lesion again in the mid LED and distal LED. So a typical diabetic vessel, and there is severe calcification, though very not seen on this angiogram in the cine images. So this is the ariocaudal view showing the LCX is also having a lot of calcium. The proximal LCX has moderate stenosis, something like 40% or maybe to 40 to 60% lesion. And then the LMC also looks a narrow caliber artery showing a disease less than 50%. So now this was a guy. I mean, this case is like, RCA is okay. There is a lot of calcium and there is a critical lesion. So with this thing in the mind, I thought of, doing PCI to the LED with a stenting from LMCI to LED, crossover stent strategy. And provisional strategy as the LCX was not much critical. So when the patient had come, because previously he had come 2 days, so he had atypical presentation before. He had warning signs which were also picked up, but also we can say that were missed. And also now he is ready for everything, but 2 days prior he was not willing for any invasive procedure. And also at the age of 40, he has so much of calcium, like the RCA looks okay, but the LCX, the LMCA or the LED is so calcific. And generally at 48, or we don't expect, but he has presented with sorry. So this is a plain cine showing eccentric calcium in the LED. So initially I took a 2.5 non-compliant balloon. The balloon was slipping. So there was a typical watermelon seeding of the balloon. So we took a Wolverine cutting balloon, 2.5 into 12, and went sequentially, slowly dilating. And then this is after the first pre-dilatation with the Wolverine balloon. The lesion looked better. And here we can see the LED is disease, there is eccentric calcium, but at least the lesion has opened up. And this is the aleocaudal view where the flow is good and also the lesion had opened up. Now, after that, I took another balloon with with the assessment, I thought that this is almost a 3.5 mm vessel. So took one 310 Wolverine and went gradually and slowly at higher and higher pressure. So first with the Wolverine and then again with the NC balloon, and did the job of pre-dilatation. Because considering the calcium, I thought of giving the good results so that we don't have any stent failure. So this was after the pre-dilatation. There was a lot of coronary spasm in between. He had ectopic tachycardia. So took him to stent. Took him to stent the LED. Now I didn't have a 3.5 stent that day was utilized, and had a 3 into 30. So the length was coming out almost 30 mm, and wanted a 3.5. It was not available. It was utilized that day, and we have less of the MNC stents and we have more of the Indian stents in our cath lab. So I took a 3 and I thought I'll make it 3.5 for dilatation. So the stent was positioned from LMCA to the normal to normal zone from the left main ostium. or the near ostium to the proximal LED till the septal artery. And after confirming the result, this was the deployment of stent. It was deployed at 11 to 12 atmospheric pressure and a very good flow. Then the regular steps as we do, we decided to do the pore dilatation. So we have written 2.5, took a 3.5 balloon and started doing the pore dilatation. So actually, we always try to do the pore dilatation, the proximal portion, but the balloon was there and was going ahead with the pore dilatation. But unfortunately, what happened that the balloon was not deflating. Now this was a new balloon, and there was a lot of difficulty in taking back the inflation device. So my assistant, he applied little force and he pulled the whole system. And in all that problem, there was the manipulation of guide, and the guide went ahead, and then it did a deformation of the stent. So this is a very close picture where actually, if we see, the stent was from the ostium, but now the stent has been deformed. And now I'm actually not able to understand whether the stent is at the distal LMC or it is at the midway between the like the origin of the LCX, or actually it has gone up to the LCX ostium, because then I took multiple projections to confirm, and then so this was exactly what was the plan. Just get out with a stent, do a pot with 4 balloon, and then do all the things and come out. But now I had landed up in the midnight with a big headache of the stent getting deformed. And then the main issue was that we are not able to see where is the ostium. I mean, where exactly the studs have actually foreshortened. If they had come up to the L6 origin, then very big chance of stent thrombosis and also recrossing and everything. So the balloon in place, I took a balloon, then I took a stent boost, and then with all that, I just thought of just going high pressure dilatation, at least the area from where I can see the stent, and then think over it. So this is the pore dilatation, and this is the picture. So here, after a lot of boosts, actually I don't have the boost images, so where I was able to understand that this stent is still coming at the LMCA. I mean, instead of the LMCA origin, it has come up to the distal LMCA. And this LED LCX being a different origin, in some views it was looking as if the one edge of the stent is like at the ostium, and in some view it was looking in the distal LM. So this is the areocaudal view where it looks as if the stent is right in the ostium, and the LMC is totally free of it. But the calcium was obscuring. We did not have imaging at our center, and also in the midnight it is difficult to arrange for imaging. So the stent boost again did not even give any clarity. In the stent boost, if you can see, the stent looks at the ostium and with some studs hanging at the LCX. So with everything in mind, there was a wire in the LCX. So decided to take another wire, cross it all along, and there was difficulty in passing the wire. There was difficulty in passing the wire into the LCX. The wire was going across some struts and not going ahead easily, I mean freely. So with lot of giving to right angle shape to the second wire, was able to go from the LMC to the LCX without the feel that I have not gone through a strut. But when I took a 2O balloon, it was not able to pass easily. There was angulation and calcium at the LCX origin, so it could not be passed. So I decided to go sequentially with 1.0, 1.5, 2, 2.5, so that the plan was to just open the struts and do a kissing balloon and then see what is the result. So went serially because the balloons were not tracking on it, because probably they were through the struts, or they were before the strut, and then the I mean, they were obviously through the strut, because in the end I realized that the stent was in the distal LMCA, and there was a lot of crowd. So with serial dilatation with 1.0, 10, then 1.5, Then this is a this is 1.5. Then this is 2 and 2.5. Finally, could achieve a proper opening of the studs across the L6 ostium. After that, did the kissing balloon dilatation. So 3.5 mm balloon into the LED and 2.5 into the LCX. So first went high pressure into the LCX at 12 atmosphere. I mean at the regular 12 atmosphere. So the balloon was opening, then went with the LED. LED I went up to almost 18, and then the simultaneous kissing balloon at 12 atmosphere each. Also, there was not much scope at the proximal zone like regular we do when we have a lot of stent into the LMC. And finally with all that headache and finally almost struggle of almost 1.5 hours, was able to achieve a good flow, a good optimization of the stent, which had got a longitudinal deformation. And in this picture, we can see that stent is at the distal end of the LMCA, and there is a TIMI3 flow, and there is even in the apicranial view, there is a good flow in the LED, and okay, I don't have the RO button. So I thought this result was good. It was almost the midnight, 3 o'clock when we finished this case, and came out. So the only thing always it was in the mind that if I have more of hanging studs or more of crowding of studs, there will be a risk of stent thrombosis. But if I optimize my results, so what was in my mind is do a check angio the next day with imaging and then take a call on it. Till that time, put the patient on IV tirofiban, also put him on LMWH and see. So, sir, shall I stop here or just continue with some theory on longitudinal stent?
Yeah, is that the last shot or you have a check angio?
No, sir, I don't have a check angio. This is the last shot.
Right. We can have a discussion here and see the theory later because we
Yes, sir. Yes.
spending hours. Thank you for presenting that interesting case and with several learning points, Dr. Pranav. I now invite my co-moderator, Dr. Himanshu Gupta, to make his comments, and then we can have a discussion and comments from the audience.
Yeah, so very good evening, everyone. I think Pranav, you did a wonderful attempt, but there are a few questions in my mind. What is the need to intervene left main? I don't know. I think the left main is not much diseased. I understand you are working somewhere where the imaging facilities are not there, but still, if you are not, hello, are you
Yes,
audible?
sir. Yes, sir. I'm there. Yeah, yes.
I think there is a good landing zone in the LED. You can simply put the LED stent and come out. And especially if you are attending at the night and it's a kind of primary.
Sir, if you, I mean, sir,
Right.
I mean, this LED actually, if you see, as we always say that the plaque of the ostium always extends into the LMCA, and at times deploying a stent in the ostial LED is more difficult if we mess up because
But that's why either you do have the imaging to do an attempting left main in a primary kind of scenario without imaging is actually disastrous. And thing is that you have chosen a 3O stent, and clearly, usually, if you do the OCT of these cases, you find the left main is
Four.
usually 4 to 4.5.
yes.
Okay. A 3 stent, it's very difficult to increase to 4.5 unless it is a Megatron from Boston. You said that you have the all Indian stents in the shelf.
No, sir,
So,
this I had taken an MNC stent. Actually, that 3.5 size was not available and there was undue demand for a good stent.
and
So that was a mistake, sir. I should have taken a regular stent because, in fact, I normally oversize my stent sometimes because that becomes more easy while doing these cases.
yeah, I do agree. And third thing is that what you are saying, it is a longitudinal stent deformation. I thought that once you did the wiring very clearly, and even after the stenting, you easily pass the wire. There is no crowding of the stent studs. Sometimes this happens once you while placing the stent, the guide hits at the mouth and this whole of the stent got displaced, right? Despite of saying it is a stent deformation. I don't know.
Yes.
Without imaging, it is very difficult to say. But whatever the fluoro you have shown, that much crowding is not seen actually. It is more of the calcium, isn't it?
Sir, actually, this particularly I have highlighted this slide. I don't know how to show the pointer.
Okay, I do agree.
Sir, in this right side, if you can see, I mean the calcium obscures, but whatever stent was deployed just it was just at the near guide. And as see, the mistake was that I took a undersized stent just for this thing, and then during it was all going very easily, and then this same balloon, when we are trying to get it back to dilate, that
And
time
the last thing is that if you have decided to go for provisional stenting, why do you have chosen and you think that the stent has dislodged and it goes to the mouth of the LED? So what is the need to go for and do the final kissing balloon dilatation?
Sir,
And
actually,
know
it
that
was looking in only the areocaudal view that the stent is gone to the LED ostium. But the way I could not enter the, after the wiring, it was not unable to enter the LCX. I needed multiple, going from 1.0, 1.5. So that every time we were able to feel it. So that was the main difficulty, because and then finally the stent, if you see here, if sir, the left image, if we can see the stent balloon proximal marker, just 3-4 millimeter distal to it is exactly where the stent
actually there is no place for KBI. That is what I want to say. There's no place for KBI. If you do the KBI, stent in the ostial left main also, isn't it? That is a diseased raw area which you have left. So how's the
no, sir, I did not extend my balloon beyond the stent was in the distal left main and exactly at the proximal, because I confirm it on stent bull, but the images of stent bull don't come to our software.
Last thing is that you know that the circumflex ostium and the proximal circumflex calcific diseased. So if it has got dissected, then what will be your bailout strategy to do the stenting?
Bailout, yes, sir. Tap stenting.
Tap
stenting.
Okay.
Sir, here what happened? Like we regularly do all bifurcation stenting, but here the only dilemma happened is that something unexpected happened, which generally doesn't happen. And secondly, then it was unable to delineate where exactly now the stent has gone. And as highlighted, imaging is very important, but that was not on the shelf.
What my approach is that if I don't have the imaging, I'm doing it at the night, cover whole of the left main first. Cover whole of the left main, do whatever you want to do.
Yes.
Otherwise, whatever the portion you leave in the left main, that part may get dissected, may have the thrombus, may have something, leads to a poor outcome, especially if you are working in a center when the OCT is not there. So I think the putting ostial stent might have give you the better results.
Yes, sir, definitely.
Sir,
my idea here was to go with a 4 or 4.5 balloon in the left main, but as the stent had almost come to the exactly at the distal edge of the left main, and when we are doing kissing, both the 3.5 and 2.5 balloon are almost at the edge of the stent. So I mean, there is no. I mean, after the deformation, we don't have any hope to take anything bigger. So I accepted that the proximal whatever edge of the stent in the left main will get optimized as per.
Okay, we want to know the opinion of sir.
Yeah, I have a few comments as well. Do you have a primary PCI program or not? Why was the patient thrombolized in the first place?
Sir, we don't have a primary PCI program because getting the paramedic staff is the only challenge here. Otherwise, the technician and we are in the
After an hour, you had to end up doing this case. So, which I thought means you could have as well.
It all happened because the assistant who was assisting the case was not the regular brother who served for
I have a couple of comments about the way the case was done. I would have done it slightly differently. Like Dr. Himanshu said, I too thought there was a landing zone, and in an acute situation in the middle of the night with a STEMI, I would have just placed a stent just a few millimeters away from the ostium of the LED and got away with a single stent without all these complications, especially because circumflex seems to have a plaque. It's not totally free of disease. There is some 30, 40, 50% of plaque. So I would avoid getting into a bifurcation in the middle of the night and without imaging, like rightly pointed out by my co-moderator. Second thing is, when you have a stent deformation, longitudinal stent deformation, the most important point is to prevent it. It is the way you handle the guide. You bring the guide way off, especially when you have put a 3.5 balloon. A 3.5 balloon takes a slightly longer time than a 3 millimeter balloon, which we have to realize. Take a long breath and count some 5 or 10 numbers before you pull on the balloon. And that is the key point in avoiding longitudinal stent deformation. I've seen some senior operators even taking off the guide, disengaging it, and bringing it right into the ascending aorta before kind of pulling on the balloon. And the first point, there is a small tip here. When you have deflated the balloon, the first point, before you pull on the balloon, just give a gentle push on the balloon. This will disengage the guide and kick it back and avoid longitudinal stent deformation. It's a very important point which you can practice, especially with 3.5 and 4 mm balloons. As the balloons get larger, the time taken for the deflation, of course, the concentration of the dye, everything matters. But the time taken for the deflation of a 3.5 and a 4 or a 5 balloon is much longer. You have to wait for a few seconds, and that little bit of impatience in the middle of the night, it will cause problems. And the third most important point I would think is, when you have a longitudinal stent deformation, the first thing you do is take a larger balloon and do a pot. This will avoid all your problems of getting into the side branch, getting under a strut and getting into the side branch, and kind of align those deformed stents. That's what you do first. And second thing is, you put a second stent and cover the entire left main. There is no possibility of leaving deformed stents in the left main, irrespective of what kissing you do. So first take a 4 millimeter stent, cover that, come to the ostium, maybe have one strut there on the same wire, on the same LED wire, and leave the circumflex wire, take a third wire and rewire into the circumflex. If you have thought of a provisional, stick to provisional. If you want to open the side branch strut, just keep the marker of the balloon into the circumflex, open the strut slightly and get out. If you still want to keep it provisional, don't do anything on the side branch, because the jury is still not out on what to do on the side branch ostium if you are thought of as a provisional, and there is no loss of TIMI flow, even though the side branch appears pinched. If there is TIMI3 flow, you can still leave it alone. Of course, in daytime, if you have imaging, things would have been different. But like Roosevelt has said, you have to do the right things at that point in time with whatever you have. And you are the best person, you are the best judge to do things at that time. So this is how I would have done and analyzed these things differently. Always in a STEMI, try to keep things very simple. Even if it looks like a left main bifurcation, just keep it simple, get TIMI3 flow, get rid of those ST elevations and the acute situation. In the cool light of the day, things are much different. When you come back next day or 2 days later, things will be there will be much more clarity. You would have imaging, you would have the support of colleagues or whatever equipment. Then you are a totally different person to deal with that case differently. But a lot of learning points, and very good that you brought this case despite so many limitations in those cases. Thank you for that presentation. We can have the next case, because that case is also slightly longer. So we can read the theory later, but whatever learning points I think we have discussed. Any comments from the audience, Dr. Rishikesh?
So far, there are no comments, sir.
Okay, so we'll start off with the second case of the day. So, like Dr. Rishikesh said, it is not a coronary case. I thought we are seeing coronary day in and day out. I'll bring something from another field which we commonly do, the carotid cases. This is a carotid case actually, but we'll stick to the theme of no thrombus. If you know the thrombus, you can have no thrombus. That means you can avoid thrombus even in a complex situation, or at least have several learning points about how to handle the thrombus in an acute situation. So this is a 71-year-old gentleman, diabetic, current smoker, hypertensive, dyslipidemia. He had no coronary symptom, had a regular ECG echo a few months back, and it was fine. And he presented with a sudden onset of left-sided weakness, and power was grade 1 in the left upper limb and lower limb. He was hemodynamically stable. Patient came within the window, and as per our institution protocol, he was thrombolized with tenecteplase. and then taken up for an angiogram and possible intervention, mechanical intervention, because imaging showed viable diffusion perfusion mismatch on CT and MRI, and there was a large vessel occlusion that was in the carotid at this time. So this is the first angiogram. You can see that there is a very critical carotid stenosis, internal carotid artery stenosis with some kind of a slow flow and a thrombus kind of streaming. There could be some suspicion of dissection at this time if you see first images, but it was mostly thrombus in this situation. So this was the intracranial angiogram, which showed some slow flow in the MCA territory. So patient was otherwise preserved, he was conscious, but he had quite significant hemiplegia. And what was done at this time? At this time, I was not present. Only this angiogram was done by the neurosurgeon, who also does some of our intracranial interventions. So this was the angiogram. They thought there is some slow flow due to some thrombus. So they just passed that same Neuromax catheter across the stenosis, which I would be very reluctant to do in a thrombotic segment to manipulate with the catheter. And then by that time, it was, I think, late in the night. It was about 1 o'clock or something, and they abandoned at that time, took the patient back. Patient was stable. In fact, his power improved to grade 3 on that day. But on the subsequent day, that is, the first procedure was on 8th, but on 10th, which was, I think, a Sunday, patient became again densely hemiplegic, and he became a little disoriented for some reason and had altered sensorium. That was the reason for taking him back on that day. And surprisingly, what we thought was subtotal occlusion had become a total occlusion. If you can see here, the internal carotid artery, which was flowing, had become a total occlusion, and that's what had led to worsening of the patient clinically. So at this time, we had a discussion again, and there was some reluctance on part of the neurosurgeon to do anything at this time, because total occlusions with acute stroke are a nightmare, and we have done in the past and ended up with mortality, especially if there is good filling from the opposite carotid. But in this case, we thought in the imaging there was viability still, and there was not a lot of dead brain tissue. So we thought we should go ahead and do something and fix this carotid. So at this time, we started the intervention. We see that total occlusion. You don't see total occlusion of ICAs as carotid intervention in an intervention case. So we saw that stump and then went ahead and wired that with the coronary system. There's a Neuromax catheter, which is slightly different from the coronary catheters in that it has a larger internal diameter as compared to the outer diameter. Our 7 French or 8 French guides have the same diameter as a 6 French or a 7 French Neuromax. So one size lower guide catheter gives you a lot of room, both for aspiration and for devices to move through easily. So once we wired it, I thought we should balloon it, but I thought we'll take a distal protection device, the spider. If it goes through easily, then no need to balloon it. We'll just stent it directly and avoid meddling with a lot of thrombus. So this is what happened after the first shot. You can see a lot of thrombus and contrast streaming. We already placed a distal filter device, which is a spider FX. Then in this particular case, we took a very special stent, the C-guard stent, which is a closed cell design with a micronet covering the stent. Why we took this stent is because of the high thrombus load and especially the acute stroke situation. Very ideal, and in some of the trials has shown better results than the other open cell designs. And implanted the stent, and we wanted to avoid a post dilatation, but there was very severe stenosis here and the stent was really close. So we did the minimal possible, that is with a 5 millimeters balloon. We did a quick dilatation and got a good opening. And then we took out the filter and the balloon, thought we had a good result. But what had happened was, once we took a check shot, you can see in this that there is a long segment thrombosis and what is looking like a distal edge dissection of the stent. So at this time, there was a lot of dilemma on what to do with this thrombus, which had probably migrated from the internal carotid bifurcation and it was sitting here up above, whether to meddle with it or leave it on anticoagulation, because patient was fairly stable. He complained of some pain in the right temporal area, but otherwise he was okay with the same grade 2, grade 3 power in the left limbs and He was hemodynamically also stable, had a transient bradycardia, but that was solved with atropine, and he was fine. But then we thought leaving such a big thrombus there, if it migrates distally, will cause a huge infarct again. You see that the distal flow is okay at this point. So what we did was, with the same Neuromax catheter, we put the catheter right up to this point and aspirated with that catheter itself, because I thought putting the filter again, that itself might push the thrombus up. And we got almost 4 or 5 pieces of big clots with that catheter. The advantage of the Neuromax is, as I said, the internal diameter is quite roomy, and it allowed us good filling, good thrombus yield at that time. With a 50 ml syringe, we did a good aspiration and got rid of that. So after the aspiration, you can see that it is better, though there is some edge dissection. We didn't do anything, we didn't meddle much with that, and exited at this time. Patient clinically improved, he became better, his power became grade 4/5 the next day, and he was fully conscious, talking, and neurologically intact, and we discharged him 3 days later with dual antiplatelet therapy. So this is the story of the patient. So those are the final intracranial shot, no major vessel loss, there is good filling of the brain intracranial vessels. So this was the 9/40 with a distal protection device and post dilatation with a 5 mm balloon, the maximum recommended size in a carotid stent. Thrombus aspiration with the Neuromax catheter and good flow, and he went home with a dual antiplatelet therapy. So just one slide about this C-guard stent. I am sure many of you would have seen it being used. C-guard has a closed cell design and also a micronet covering the stent area, and it has that pore size is 165 micrometer. It's a monorail self-expanding open cell nitinol stent covered by PET micromesh. Some of you can remember, we used the M-guard in acute MI situations for a while, but because of the high restenosis rates and side branch loss, we gave it up after some time, quite some years ago, I would say more than 10 years ago. And after that, this stent was not available for coronary use, but for carotid use, I think it's a good stent. If you see the various stents, the open cell almost has 1900 micrometers, 1050 micrometers, and all these cells, all these stent designs can cause distal embolization even up to 30 days after an acute carotid stenting because of the scissoring effect of the expanding nitinol mesh. It cuts off the plaques and causes distal embolization, which can happen up to 30 days. So when you count a small stroke, you have to take into account the events which occur up to 30 days after a carotid stenting, not only the acute in-hospital events. This is what the stent looks like, and when you deploy it, the self-deploying design deploys itself. There's some loss of flow in the external carotid, but it's not important. When you see on the next day, the external carotid is one artery which is very, very shy artery, I would say, and goes into spasm very easily, but it recovers over the next day, and even an occlusion is not much of an issue. So this is a distal protection device which we used. Some of the carotid operators, if they use a C-guard stent, they do not put a spatter effect, saying that the pore size is almost like 70 to 200, and the stent itself, the pore size is much lower. But I still put it because in distal embolization, I feel personally is still an issue when you post dilate. So that's how we used spider effects in this case. And market clinical improvement, grade 4 power in limbs. Patient walked home. Luckily for us, the previous carotid occlusions which we have done, the acute occlusions, there is a very high mortality, almost 50-60% mortality, I would say, in a total occlusion as opposed to a subtotal stenosis with preserved flow. So this is the story of the patient. So the key takeaways from this is awareness about thrombus in acute clinical settings. Thrombus handling, which has to be in all possible ways, whatever you have with you, you use it. Do not feel shy to use a distal protection, a closed cell design of the stent, very gentle handling, pre-dilatation, post-dilatation, aggressive, trying to optimize the stent, all these things have to be avoided. Avoid aggressive ballooning at all times. If a self-expanding stent shows even 30-40 residual stenosis, don't try to optimize like in the coronary. The carotid, less is better. And mechanical aspiration in this particular case helped, but I would be reluctant to put a catheter and aspirate a thrombus in the carotid without distal protection. But it established good flow and gave us a good result in this particular case. use everything, the mechanical thing, the pharmacological thing. We have used a lysis, we have used antithrombotics, and antiplatelet therapy will take care of the rest of the things. So know your thrombus, and that will lead to no thrombus and a good outcome for the patient. Thank you all for the very patient hearing that you gave to me. And if there are any questions, I'll be happy to answer.
Yeah, thank you, sir. I think it is a wonderful presentation, and very rarely to see such a case in which the patient has recurrent strokes. Initial attempt thrombolysis successful, and again the patient has a restroke. So the intervention is the only option in such cases. Use of the distal protection device is the must, I think, and you did wonderfully. And I have limited experience in carotid interventions, so I think putting a distal stent is not that much effective, no, sir?
Yeah. Beyond that extension of stents, very high restenosis rates. So
Ayo.
especially the internal carotid bifurcation will restrict the stents to about 40 millimeter. And if you get a good flow with a minor stenosis also, there is no evidence to show that extending stent unless there is a dissection. Sometimes these thrombosis and that streaming of flow, acute carotid dissections, especially post-trauma, younger patients with acute strokes, you have to consider. In that case, you see a kind of a pencil tip like carotid. In those cases, you may consider extending the stent intracranially with good results.
Thank you.
So you just put a wire and then you put a microcatheter across the dissected segment and inject in the microcatheter. If you see a good flow, then it means that there is a dissection which is occluding the lumen. Then it is worthwhile putting another self-expanding stent into the.
And unlike coronaries, like when you are putting the stent from common carotid to internal carotid, is it not mandatory to put a wire in the external carotid artery also?
External carotid, you can ignore it. There's no point in trying to protect the external carotid.
Oh, nice. Thank you, sir.
Any comments, Dr. Pranav? Or from the audience, any comments?
Very excellent case, sir. I mean, lot of learning from the case.
Yeah.
And very rare to get patient presenting multiple times, and as a coronary, just like a coronary, you have opened up the heart.
Yeah, that's how cardiologists handle carotid. I always feel cardiologists always handle the vessels better, though we should not claim excessively ego boost ourselves. Any vessels are better handled by cardiologists because we use gentleness in the coronaries. The same thing comes to the periphery. Even when we do a lot of below knee cases, we treat them exactly like the coronary. We give eptifibatide, we give nicorandil, try to treat the thrombus very gently, try to aspirate, which the peripheral and interventionalists, they do a great job, interventional radiologists. But to treat them like if we tell them we should use some antiplatelet agents, IV, they say why, and that much of understanding is less, I would feel. Like we treat them with dual antiplatelet statins in 40 milligrams. They don't treat them like that. Yeah. So
even the heparin doses are not matched as per the ACT protocols.
They give 2000.
They will use very low dose, 2000, 3000 units of heparin.
And sir, what is
It's better to kind of mentor your colleagues with respect to interventional radiology or even neurosurgeons. We do interventions. They need to be mentored by cardiologists, at least in the initial phases. It's cooperation rather than competition. It may not be our field, but some things we will add to the value of the procedure and to the patient, which has to be taken into account.
What is the discharge advice? Do you added the antithrombotics like warfarin or Novax in this?
Yeah, in this particular case, there was a concern about intracranial bleeding. There is an infarcted tissue. The tissue which bleeds in the brain is the infarcted tissue. And at that particular moment, it's very difficult to quantify how much of infarct is there. Though the patient is neurologically intact, it's very difficult to quantify. And they can bleed up to 10 days, 2 weeks. So at follow-up, we'll see this patient again, maybe do a non-invasive imaging and do a brain imaging also. If the infarct is small and still there is evidence of some thrombosis, then we'll put him on anticoagulation, certainly. Yeah.
And what were the antiplatelets here? The clopidogrel and aspirin or ticagrelor?
Clopidogrel and aspirin. I gave clopidogrel and aspirin. Yeah.
So there are no comments in the chat box. So I request Dr. Keshav Murthy sir to give concluding remarks, and then I'll go for vote of thanks.
Sir, I have one question, sir, before the concluding remarks. Like yesterday, I had a patient with an internal iliac stent. For a fitness, he had a sinus mass and had to be operated on an emergency basis. So the stent was implanted with a 3 months prior. Now, in such a scenario, suppose this patient needs a interruption of the DAPT, like for any other event. So, how much, like bare minimum time, like the carotid stents, how much bare minimum time of dual antiplatelet therapy is must?
Carotid stents are okay after 30 days.
30 days.
They can be on aspirin 75. Actually, if you have a coronary, left main, and carotid, there are several series of studies showing a correlation between left main stenosis and carotid. A large number of patients have left main disease, have also carotid disease. So, carotid disease is treated first and given dual antiplatelet for about 7 days. At the end of 7 days, stop the clopidogrel. On aspirin, he is operated. So it's quite safe because they are large caliber stents. They don't thrombose that easily. I've never seen a carotid stent thrombose so far. Thank you. And at the outset, I would like to thank Emcure for creating this wonderful platform of learning and sharing of all the experiences of various brilliant operators across the country, and gives a great opportunity for the younger interventional cardiologists to bring up with their cases and discuss all the problems, so that every day we can do things better and better and give good outcomes for our patients. That is what is our ultimate aim in life, and we always try to stick to that and achieve that. And thank you, Dr. Pranav, for bringing that very interesting and lot of learning points. Now that you go wiser, and next time you are confronted with such a case, we will definitely, I am 100% sure you will put all these points into practice and look at things slightly differently. I really encourage you to come forward and present more such cases in the future. Thank you for that brilliant effort, and I thank my co-moderator, Dr. Himanshu Gupta, for the contribution with the wonderful comments regarding both the cases. And I thank all the audience for being here, and I am sure it is time worthwhile spent 1 hour every month. It is not too much of time, but it's a brilliant learning experience with no much of theory and more of practical points. Thank you all for that.
Thank you.
Before we conclude, let's express our gratitude to all those who made this program possible. I would like to express my sincere gratitude to our esteemed course director, Dr. C.B. Keshav Murthy sir, and our distinguished moderator, Dr. Himanshu Gupta sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Pranav Shamraj sir for his insightful case presentation. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. And I would also like to thank our course director, Dr. Keshav Murthy sir, for bringing interesting case today. And thank you for that. I would also like to thank our esteemed audience for their time, continued love, and support for the No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you, sir.
Exactly on time.
Yeah. Thank you.